So I'll be starting with a quick recap from last week. Last section we had, I summarized the electrophysiology of the heart. Not really in depth, but I promise to streamline it to what you need to know and those things that are actually relevant to the ECG interpretations. So I was able to talk us through the peculiar characteristics of cardiac muscle tissues. I talked us through the cardiac activations, the rapid activation and sequential activations. We discussed the conducting system of the heart as well, the natural pacemaker, the SA node, moving to the AV node, the bundle of E's, the bundle branches, and the Purkinje. Okay. We talked about the definitions, the indications, and the forms of ECG as well. We spent some time to talk about the direction of ECG. I gave us a is it a time now when I said, okay, you could take that to be 450 hour. Okay, the direction of the normal cardiac activation. Okay, so if you are joining us for the first time, you can, at the end of this section, you can go back to the old class, the last week section, then update yourself so you can follow us. Okay, so we talked about the ECG directions. We talked about the upward deflections, the positive deflections, what makes it positive, then the downward deflections, what makes it negative, the isoelectric line, which is what we see as a straight line. Okay. So we talked about the components of ECG as well, where we identified the P wave, the QRS complex, the T wave, and the U wave. Okay, so and what each of them specifically represents. Okay. So if I can put us to test, just a quick knowledge check. I'm sure I mentioned this in the last section. Okay, so if anything is going on in the atrium, let's say the atria now, which of them in the atria, which of the components of the ECG will be displaying that? Which of will you be seeing it on the P wave? Will you be seeing it on the QRS complex? Will you be seeing it on the T wave or the U wave? Okay, activities going on in the atria. Which of these waves will be showing it? So if you can put that in the chat box, let me see who is a true and faithful participant. Okay. So we closed last week by talking about QRS transition. Okay, thank you, Olubomi. She said P wave. Okay, I'm not going to say if you are correct or wrong. So I'm just going to wait if anyone else has something else to say. Okay, so we talked about QRS transition, and I told us how QRS should start negative from V1, then gradually becoming positive towards V6, and that's the QRS transition. I explained to us why as well, and that's closely related to the direction of the ECG that we described, because the V1 is closer to the point of activation. It's closer to the right atrium where the SA node is, and the impulse is traveling away from that point of activation. So the closest electrode, the closest lead to the point of activation is the V1, and that is expected to be negative. And the more it moves away, it moves away from the point of activation towards V6, it gets more and more positive. Okay, so if there is any discrepancy with that transition, if there is any discrepancy with that movement, then something is wrong somewhere. Probably there is an ectopic impulse coming from somewhere else other than the other than the SA node. Okay. Okay, I've got Chisholm saying P wave. That is absolutely fantastic. So that is correct. So electrical activities in the atria will be showing on the P wave. Okay, so the normality, the abnormality of the atria can be assessed from the P wave, which is absolutely brilliant. Well done. And the same applies to QRS complex for the ventricles. Okay, so tonight I'll be talking us through the intervals and the segments in the ECG. Might have been hearing a lot of intervals, segments in the ECG. Then I'll be discussing the leads and electrodes as well. We'll be discussing the leads and electrodes. We'll be talking about Einthoven's triangles. Okay, and if time permits, I can talk us through the clinical scopes of the leads. Happy? Yeah. Okay, so just a further recap, just because I'm going to be building on this, so I've decided to bring this forward all over again. So the depolarization and repolarization of the heart is represented by the different waves. Okay. By the different waves. The major waves in the ECG are the P wave, QRS complex, and the T wave. Okay. The P wave represents the atrial depolarization, and I said to us, for the benefit of this training, when I say depolarization, just take it as contraction. Okay, just take it as contraction. And when I say repolarization, you take that as a relaxation. Okay. Depolarization, contraction, then repolarization, relaxation. There are a lot of activities surrounding the depolarization and repolarization, all these action potentials and all these all these chemical exchanges. You really don't have to bother your head with that, to be honest. Okay, so P wave represents atrial depolarization. QRS complex represents ventricular depolarization, which is ventricular contraction. Q wave is the initial negative deviation in ventricular depolarization. Okay. I'm sure you can see it on my screen already. So the R wave is the positive deviation in ventricular depolarization. For the benefit of people just coming in, when we say positive deflection, we mean upward deflection. Then negative, positive deflection, upward deflection. Then negative would be downward deflection. The S wave is the later negative deflection after the R wave. The T wave represents ventricular repolarization, which is ventricular contraction. There is a U wave somewhere after the end of the T wave. So it's just something like this. If this is the P, of Q, R, you have X, then T, then U will be a different, U will be a second positive, another positive deflection after the T. So it's assumed to represent the repolarization of the interventricular septum and the papillary muscles. And I mentioned to us last week that it's mainly prominent in hypokalemia. Okay. So there is no way to represent the atrial repolarization simply because this coincides with the ventricular depolarization. I explained that as well. Okay, I hope that is fine. So now to the intervals and the segments. Intervals and segments. So beyond the regular P, Q, R, S, T, and maybe U, there are few more components. Okay, and so that's where we have the intervals and the segments. So the PR interval to start with, this is the period from the onset of atrial depolarization to the beginning of ventricular repolarization. Okay, and I want you to pay a bit of attention and look at my screen. So this is the PR interval here. Then if you look at this red column, that's the PR interval, and it starts from the beginning, from the onset of P wave to the start of the Q wave. And that is just what we are putting into words here. Okay, so that's the period from the onset of atrial depolarization, which is the onset of P waves. So instead of saying onset of P wave, so just make it more formal. Okay, so onset of atrial depolarization, which is the P wave, onset of atrial depolarization to the beginning of ventricular depolarization. Ventricular depolarization starts with Q. You know, QRS represents the ventricular depolarization. So the beginning of ventricular depolarization is Q. So the start of P to the start of Q is what we measure as PR interval. I hope that is clear. So that's what we measure as the PR interval. This is very significant because when we get to the point of calibration, you will understand the measurement of ECG paper. Okay. I appreciate that this illustration, this image now is on a plain background. Okay, but on the ECG, it's going to be on a calibrated paper. So it's easier for us to measure this interval. So there is a range for this, for the interval. Okay. The range is 0.12 to 0.2 seconds. Okay, so I don't want to bother you much with that yet. Okay, so when this is significantly shorter, what it tells us is there is a bypass of the, when we are talking about the conducting system of the heart, when we were discussing that, I mentioned to us that from the SA node to the AV node, there is meant to be a period of delay. It is this delay that we measure as PR interval. Okay, there's meant to be a period of delay. That's just to allow for some feelings. Okay, so that delay is meant to be just for 0.12 seconds to 0.2 seconds. When it's lesser than that, it shows that there is a bit of bypassing. Okay, maybe in case of Wolff-Parkinson-White syndrome, where you have a delta wave, or significantly, if it's longer, if the PR interval is longer, that means the delay is longer. Okay, then that's diagnosis heart block. That diagnosis heart block. So if you are hearing maybe type 1 heart block, or type 2, or whatever, first degree, second degree heart block, or third degree, this is the primary physiology of the heart block. So when the PR interval is longer than 0.2 seconds, it is heart block. Okay. So as we move on, then you get to understand how you can differentiate a first degree heart block from a second degree heart block, or maybe it's type 1 or type 2 or whatever. But for today, just take that understanding with you, that when the PR interval is longer than 0.2 seconds, then that is heart block. It is very significant in understanding of interpreting ECG. Okay. So that is what, as a PR interval, that's what the PR interval represents, and that is as the significance of it. Okay. Abnormalities of the conducting system may lead to transmission delay, thus prolonging the PR interval. A PR interval less than 0.12 seconds suggests that there is electrical impulse, that the electrical impulse is bypassing the AV node, as in Wolff-Parkinson-White syndrome. I think that's just what I've done. I've said that already. PR interval longer than 0.2 seconds, diagnosis first degree heart block. Heart block is the same as AV block. So the next segment here is the PR segment. The PR segment. So if you look at the green column here, this is the PR segment. I want you to pay closer attention to this. I'm sure with the understanding you've had so far, you should be able to define what PR segments represents here. And subsequently, you'll be doing that for me in the chat box. So, but let me help you with this. You can see this PR segment here started off just after the P wave and stopped before the QRS. Okay, so if you want to put that into context, so that would be if you want to put that into context now, then you can come back and say that's maybe an isoelectric line from the end of atrial depolarization, which is the end of P wave. Remember, P wave is atrial depolarization. Okay, so isoelectric line, or if you like, you can just say distance. I can take that from you at this stage. Okay, but an isoelectric line from the end of atrial depolarization to the onset of ventricular depolarization. Does that make sense? Ventricular depolarization is QRS, isn't it? And the start of the QRS is the Q. Okay, so and this segment that we are trying to make sense of now is just the distance. It's the isoelectric line between the end of atrial depolarization to the beginning of ventricular depolarization. Okay. So this is an isoelectric line from the end of atrial depolarization to the beginning of ventricular depolarization. It's quite simple, just as simple as ABC, once you have background understanding of what each of the main waves represents. So it's easier for you to make sense out of these segments. Okay. and I want you to start thinking about the ST segment and the QT segments, I would like one or two people to put that into context for me in the chat box. So if I just ask you to tell me, to describe for me in your own words what QT interval represents and what ST segment represents, I'll come back to that in a bit. Okay. So while you are doing that, the clinical relevance of PR segment is enormous. Okay, as a matter of fact, it's one of the key features we use to diagnose pericarditis. It's one of the key features we use to diagnose pericarditis. When this PR segment is depressed, then it suggests pericarditis. That's if it comes alongside a widespread ST elevation. Well, I will come to ST elevation later. Streamlining you to the PR segments. When I say depressed, this is a straight line here. Where's it now? This is a straight line. This is a straight line here. It's an isoelectric line. It's meant to be a straight line. So sometimes you see it depressed and sometimes you see it elevated. Okay. So when you see it depressed, it's a sign of infection, sign of pericarditis. That's one of the key things you look out for when trying to interpret an ECG. So this is an isoelectric line from the end of atrial depolarization to the beginning of ventricular depolarization. After the P wave, there is a brief return to isoelectric line resulting in the PR segment. So that's the straight line there. I hope I have people working on the ST segment and the QT interval for me. If nobody is typing, I'll just keep it. And like your high school teacher will say, you just take that as assignment. You don't have to be right, just type whatever is on your mind. That's absolutely fine. So I hope we can make sense out of these PR segments now. You can see it just after the P wave and before the Q wave. And that is what we are talking about, and I've just given us a bit of tip. A depressed PR is usually seen in pericarditis alongside the widespread ST elevation. So the next interval I'll be talking to us about is the RR interval. Okay, this is quite as simple as ABC as well. Just from the nomenclature, you can start processing what it actually means. RR interval, that's just the distance between a R wave and another R wave, or a two consecutive R wave. I think that makes it two consecutive R wave. Like you can see on the screen here, this is an R wave. R wave, that's the tallest. You can see that's the peak of the ventricular depolarization, and you can see it here as well. Okay, so when you have two consecutive R waves, the distance between the two of them, we can measure that as RR interval. On a normal day, RR interval is meant to represent the normal cardiac cycle. It's meant to represent normal heart rates. I said on a normal day. There are times where we have AV, atrioventricular dissociation, and atrial rates can be different from the ventricular rates. Okay, but in a normal situation, this is what we count as ventricular rate, and this is what myself and yourself, this is what we palpate on patients and as pulse rates. Okay, this is the end. When you look at the end of a cycle to the start of another one. Okay, so we have a QRS. We have a QRS complex here. We have a ventricular contraction here and another ventricular contraction. Okay, so this is a complete cycle. There is a contraction here and the start of another contraction. So this is a complete cycle. And why you need this is, I just imagine maybe you are sitting down at the nurse's station and you are looking afar off, just looking at the monitor from distance. And God help you if, like myself, maybe you use glasses. So there is a limit to how far your scope of sight. Okay. From distance, one way you can actually see, okay, this patient's heart rate is dropping, this patient's heart rate is increasing, is you understanding this RR interval, just making sense out of the RR interval. So if the heart rate, if I may ask you, if the heart rate is reducing, maybe your patient is becoming brady, having bradycardia, would this gap be increasing or will it be decreasing? RR interval, will it increase or will it decrease? I just need a feedback on that. The RR interval, if the patient's heart rate is dropping, because I told you that's the end of a ventricular contraction to the start of another one. So if this gap, if the patient is now having maybe a heart rate of 30, so will this RR interval be widening or it will be reducing? Okay, someone says increase. Any other person? Anyone else? Okay, okay. All right. So you are absolutely right, Olubumi. Very well done. So when there is bradycardia, you will see a significant increase in this RR interval. Okay, and it's just logic. It's just logic. So what that means is maybe there is a ventricular contraction here, and it takes forever before another cycle is completed, and it takes another long, maybe another eternity for another cycle to complete. So definitely this gap is going to be getting wider and wider. And even without palpating your patient, just from distance, you're just going for your break and you just catch a glimpse and you look at the monitor and you can actually come back and say there's something going on with these patients. And that's the essence of this series. So you can be a viable, a potent lifesaver. Okay, so I need this tachycardia definitely the gap is going to be shorter. So maybe we have a ventricular contraction here, then just shortly after that we have another one. Shortly after that we have another one. Shortly after that we have another one. Shortly after that another one. So the RR interval is going to be extremely shorter. Okay, and when you start having this, so when you hear them talking about maybe ventricular tachycardia, okay, I'm sure many of you've heard about VT, ventricular tachycardia. You've heard about I don't want to be talking about fibrillations yet now, but you've heard about tachycardia. Obviously you've heard about ventricular tachycardia, which is a common rhythm. Okay, this is how you identify that, okay, there is tachycardia going on with these patients. So it's not rocket science like many of us have taken it to be. It's just if you take your time to understand the basics of this ECG, okay, you will find it easier than you thought. Okay, find it very, very easy. So this is one key way for you to be able to identify, oh, there is a VT, there is a ventricular tachycardia going on there, because the gap between a ventricular contraction and another ventricular contraction is getting shorter and shorter and shorter. Okay, I hope that makes sense. Okay, so let me see the assignment I gave people. Do I have? I think it's only Olubumi that's here with me tonight. Okay, well done, Olubumi. She said ST segment is the isoelectric line from the end of ventricular depolarization to the onset of ventricular repolarization. Applaudez-moi. That's absolutely fantastic. Well done. That's quite impressive. Okay. So ST segment is the isoelectric line from the end of ventricular depolarization to the onset of ventricular repolarization. You can't have it more than that. That's perfect. Very well done. So this is just so the QT interval, nobody's typing that yet. So I just, from the screen, we can see the QT interval here in blue. Okay. You can see the QT interval here. Okay. So the QT interval, that's the period from the onset of ventricular depolarization. Onset of ventricular depolarization is Q. Okay, that's Q. Onset of ventricular depolarization to the end of ventricular repolarization. T is the ventricular repolarization. So from the start of ventricular depolarization to the end of ventricular repolarization. Okay, that's the QT interval. And once again, if you don't understand all these fundamental things, this is when ECG interpretation becomes overwhelming and mysterious. Okay, because there's no way you can build on a faulty foundation if you don't know what the QT interval is. Then I'm afraid you won't be able to go anywhere with your interpretation if you don't know what the PR interval represents. If you don't know how to measure it, you don't know where to measure from and to where, then you can't make sense out of ECG. Okay, so and this is why this class is very important. And I'm happy some of us are getting it already. Okay. So lastly on that is the ST segment, which someone already defined for us. So it's an isoelectric line. This looks like she just copied it from my screen. Isoelectric line from the end of ventricular depolarization to the beginning of ventricular repolarization. Absolutely fantastic. Okay. ST segment is one of the most important, or let's say most significant components of ECG when you are talking about interpretation of ECG, because the changes of ST segments can tell you a lot of things. The changes in the ST segments can tell you a lot of things. So just mere looking at an ECG, you have an ECG paper report on your hand now, just mere looking at the ST alone, you can start making sense of what and what this represents. ST segment, just like the PR segments, can be depressed or elevated. Okay, I told us depressed, because you see it maybe a downward depression like that, then it can be elevated. Okay. When ST depression is usually seen in left ventricular hypertrophy. Okay. You can see it in digoxin intoxication as well. Okay. So if your patient is on digoxin, regular meds digoxin, then for one reason or the other, he had ECG done, then you can see the ST depressed, then it's time for you to call the attention of the physician to it. Okay, so it's one of the early signs of digoxin intoxication. And ST elevation as well can be seen in pericarditis, especially when it is widespread. When I say widespread, I mean like all throughout the leads. Okay, just all the 12 leads have the ST segments. You have the ST segments elevated, then we can diagnose pericarditis, especially when it comes with PR depression. Okay, remember I told us the other time. So a combination of PR depression and widespread ST segments is a diagnosis of pericarditis. Well, I'll come back to all those information in detail at the appropriate time. I'm just giving us a bit of whetting our appetite that way. And I'm sure you might have heard of STEMI and NSTEMI. When they say ST elevation MI, non-ST elevation MI. You understand? When you hear, so that tells you that it still is also significant in diagnosis of myocardial infarction. Okay, so it's also significant in diagnosis of myocardial infarction. So that's where you hear NST, I'm sure you might have seen it, or STEMI itself. That's just ST elevation MI or non-ST elevation. So some MI comes with ST elevation, some don't come with. You understand the difference at the appropriate time. I hope that makes sense. How many minutes have we got left? Okay. Okay, so the ECG leads. I'll just talk about the leads quickly before I let us go. The standard ECG uses 10 electrodes to generate 12 leads. I'm going to show us that tonight in a bit. The electrodes make contact with the skin and the leads are generated on the ECG paper. I've seen even the so-called experts using leads and electrodes interchangeably. Okay, they are different. Okay, and I want you to take that away from me today. Okay, the leads are what you can see on the screen here. That's what you see on the paper. There are 12 of them. If you can see my screen from wherever you are joining from, you can see ECG paper. We always label it for you. You see 1, 2, 3, blah, 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 like that. You see them labeling it, and there are 12 of them. These are leads. Okay, leads are abstract. They are not something you can see, or they are something you can touch. They are not something you can touch. Okay, leads we only show on paper or show on or display on the machine. Okay, that's what the computer generates. Those are the leads. Okay, the electrodes are the adhesive tape. Is it the tapes now? The electrodes are the ones, the stickers, the adhesive stickers that we place on patients. That you place on patient's chest or place on wherever you are placing it. Those are the electrodes. Okay, those are the electrodes. So don't miss them up anymore. Okay, so ECG leads, they are what you see on the paper here. That's what they are generated on the system. Then the electrode, those are the stickers that you use, okay, on the patient. So it's actually the electrode that makes contact with the patient and not the lead. Okay, so back to the leads now. There are 12 of them, 12 leads, then 10 electrodes. So the leads are categorized into 3 groups. So we have the precordial leads. Those are the chest leads. And that's V1, V2, V3, V4, V5, V6. In America, I think they call it C1, C2, C3, C4, C5, C6. It makes no difference. Okay, it's just nomenclature. Okay, so V1, V2, V3, V4, V5, V6, or C1 to C6. Those are the chest leads. Okay, those are the chest leads. And as you can see on my screen, on the right side of this ECG paper, ECG strip, you can see V1 to V6. Every ECG machine, I don't care what the maker or the model is, they will always label it for you. Okay, so you don't have to worry about it. Some of them I label it as C1 to C6. It doesn't make any difference. So these are the chest leads. Then the second group are the augmented leads. The second group are the augmented leads. The augmented leads are AVR, AVL, and AVF. Okay. Augmented vector of the right, augmented vector of the left, and that of the foot. So you have it here. If you look at the last three leads showing on my screen here, these are the augmented leads. So you have AVR, AVL, and AVF. Okay. I'm going to show us what each of them shows and how they are generated. Okay. So the last group of leads are the limb leads. These are the limb leads. So the limb leads, you can see it on the screen here. You have 1, 2, and 3. Those are the limb leads. Okay. So the limb leads, there are 3 of them. Lead 1, lead 2, and lead 3. The augmented lead, you have 3 of them: AVR, AVL, and AVF. And the chest lead, there are 6 of them: V1 to V6. Coming together, that gives you 12. And that is where we have the standard 12 lead ECG. I hope that makes sense. Any concern, any question from anyone? Okay. So that is that's how we get the 12 leads, the standard 12 leads ECG. Okay. I'll take us to the electrodes quickly. So like I was trying to explain to us, so the electrodes are the stickers you use on the patient, and you can see that in the image showing on your screen. There are different types of electrodes. Well, there are some that are vacuum that you press like this. There are some like alligator, like an handcuff. But they all do the same thing. Okay, they all do the same thing. So, and there are some that are just like stickers, like you are there. So we use 10 of them to generate the 12 leads. So the 12 leads that I've mentioned to us, we actually use 10 of these electrodes to create the 12 leads. And that will be the next thing I'll be showing us. But prior to that, there are 2 categories of electrodes as well. So we have 6 chest electrodes as well. That's just consistent with the 6 leads. That's V1, V2, V3, V4, V5, and V6. Those are the 6 chest electrodes. So then we have the limb electrodes. There are 4 limb electrodes. I'm sure we know that we all have just 4 limbs. So it's easier to relate with that. So we have the right arm, left arm, right leg, left leg. So that's RALA, RL, LL. Most times they are color coded, but it's best to read it out. Don't be proud. Okay, just read out the label, because the color is different from Europe to America. Is different. Understand the red, yellow, green, black norms, but it's not always like that. So in case wherever you are listening from, in case that's not the color code you have there, just take it and look at it. So it will always be written on it. So you have the RA, LA, RL, and LL. So that gives us 10 electrodes. Okay, so that gives us 10 electrodes. These are just further examples of electrodes. So lastly, for tonight, I'll just talk about the Einthoven's triangle. How many of us have heard of this before? You've heard of the Einthoven's triangle? Quickly. Nobody? I'm sure we've all heard of it at some point. Probably you just couldn't make sense. It just couldn't make sense out of it. Okay. Let me simplify it for us tonight. So pardon my diagram. If this is Dorothy's chest, so this is Dorothy's chest. So this is Dorothy's right arm. This is Dorothy's left arm. That one thing I didn't tell us when I was talking about the electrode, I said there are 10 of them, isn't it? There are 10 of them, the 6 chest electrodes and the 4 limb electrodes. Out of the 4 limb electrodes, that of the right leg is actually neutral. Okay, that of the right leg is neutral. And what that means is it's really not, it's not doing anything. Just, I might be wrong, well, technically it's not doing anything. So literally, we're actually using 9 electrodes to generate the 12 leads. So the right leg is a neutral electrode. Anyway, so come back to why I made reference to that was to generate this lead, we are not going to give any reference to the right leg. We are not giving any reference to the right leg. So we are working with the right arm, left arm, and the left leg. So the right leg is not contributing anything, as it were. So it's just a neutral. Okay. So these are the 3 limb electrodes that we are working with. So if you draw an equilateral triangle from these 3 electrodes, now I've told us why this was excluded. It's because it's neutral. So we have just this inverted equilateral triangle now from right arm, left arm, and left leg. So let's assume the heart. Let's assume the heart is somewhere here. So let's assume this is Dorothy's heart somewhere here. So this is how it works. Okay. So the potential difference from I'm trying to change the color now. The potential difference from right arm to left arm, like the electrical activity between this right arm and left arm, is what we measure as lead 1. That's what shows as lead 1. Okay, that's what shows as lead 1. Okay. The potential difference, the distance between the right arm here and the left leg here, is what we measure as lead 2. What we measure as is what shows on the screen as lead 2. You will agree with me that when you see an ECG report or an ECG printout, you are not going to be seeing LA, RA, LL on the paper. So instead, you'll be seeing the leads. So you need to understand how these leads are generated. Okay, so you can know where they come from. Okay, so from the right arm to the left leg, from this electrode to this electrode is what the system measures as lead 2. Okay, and from the left arm to the left leg on this side is our lead 3. That is simple enough. So this is how ECG leads are generated. This is how ECG leads are generated. Let me take you a bit ahead of time now. If you are conducting ECG on the patient and you've attached all your electrodes, you felt you've attached it properly, and there are a lot of interference or artifacts. When I say artifacts now, maybe there are some abnormalities showing on the screen. Okay, you know when your television or your screen, your phone screen is getting faulty and it's just shaking like that. And you notice that artifact, that interference is applicable to your lead 1 and your lead 2. That tells you that your right arm electrodes is the one that needs adjustment. Then you can look at it on the screen and say, why is this lead 2 and 1? They are maybe having wandering baseline, or they are just not stable on the screen. Then you can know you need to adjust the electrode you've placed on the right arm. Probably it has fallen off, or probably there are a lot of ears on the patient's hand, or the cable is twisted or anything. Then this will give you an idea where. So that's when you are troubleshooting, it gives you an idea where this is coming from. The same thing applicable if you have lead 2 and lead 3 involved in that nonsense, then you can know, okay, let me check the electrode I placed on my patient's left leg. Just be sure it's properly secured and it has not fallen off. Okay, so you don't have to be exposing the patient and start walking your way from V1 to V6 and going right hand, right leg, and just going over like a Christmas Christmas chicken. So you already have an understanding, you have a focus in mind, you know where you need to check when you see that. That's just for you. We'll come back to that at the right time. I think I kept saying that. So we still have a long way to go. Okay. So I've told us how lead 1, lead 2, and lead 3 are generated, and you can see that on the screen. Another thing you need to know another thing you need to know is how the augmented leads are generated, and it's still the same illustration. So I remember I told us we have the heart in the center here. So if you draw a line from this right arm to the heart itself, so the potential difference between the right arm and the heart is what shows as the AVR. Okay. When you see R, you know it's right. So we have a close relationship with the right arm. So AVR, right arm. So potential difference from the lead 1, 2, 3, they are just the relationship between the electrodes themselves, like from the right arm to the left hand, then from the left arm to the left leg. But now their relationship with the heart itself is what gives the augmented leads. So from the right arm to the heart is what shows as AVR. And from the left arm to the heart, that will be the AVL. That shows as the AVL. Then from the left leg to the heart is AVF. The F here is like the foot. Okay, so AVF. So I hope this is simple enough. So if you look at this all together, take your eyes away from the electrodes now. we did all this, we generated all this with just 3 electrodes: the right arm, left arm, and left leg. Okay. But like I told you, when you have your ECG report, you are not going to be seeing right arm, left leg on the paper. Instead, you'll be seeing the leads. Okay. So if you look at this now, we've been able to generate lead 1, lead 2, lead 3, okay, AVR, AVL, and AVF, and that's a total of 6 of them. These 6 of them plus the 6 chest leads, which is quite simple, the V1 to V6. That gives us the 12, the standard 12 leads ECG. I hope that makes sense. So this is how we use the 10 electrodes. To be honest, they're actually 9, like I told us. So because we use 3 here and there are 6 chest leads, so it's actually 9 electrodes that we use to generate 12 leads ECG. I hope that is simple enough. It is this Professor William Einthoven that theorized, that started all these jargons. And that's why they named it after him. So this triangle that I've been illustrating for us is the Einthoven's triangle. Does that make sense to anybody? Any question, confusion, clarification? So this is just image of what I've been talking about. So you can see the right arm, the left arm, the left leg. Then you can see how the leads are generated. You have the lead 1, 2, 3, AVR, AVL, AVF. So this is Einthoven's triangle. Okay. This is how they use it to generate a 12 lead ECG. And another takeaway before I let us go, another takeaway is it is this same understanding that gives birth to the 3 lead is 3 cable ECG and 5 cable ECG. Okay, I'm sure maybe for continuous monitoring, sometimes we use just 3 cables. So, and this is just it is this understanding that gives birth to that. So you have just an electrode on the right arm, another one on the left arm, then another one for the left leg. And these are used for continuous monitoring. Okay. You agree with me that if your patient is just maybe in ITU for continuous monitoring, you are not going to be placing 10 electrodes on the patient. Okay. For continuous monitoring, we use just 3 cables, and this is the idea. So this is just the idea, because to be honest, it's just the 3 of them that are capable of generating these 6 leads. So if you need more, then you can proceed and do a complete 12 lead ECG. The same applicable with 5 cable ECG. So with 5 cable ECG, they have another one for the right leg and one of the chest electrodes. So that of the chest, it can be anywhere from V1 to V6. And if it's maybe an intraoperative monitoring you are doing and your patient is having thoracic surgery, it can be put posteriorly as well. It doesn't really matter. And sometimes where it matters, it depends on which part of the heart your attention is, maybe the lateral, the inferior part, or the medial side, or which section of the heart you are interested in, and that would influence where you are putting your chest electrode. But with the 5 cable electrodes, that's it. I have a video I've done maybe about 3 years ago now. It's still very clear and relevant. I'll share the link in the comment section, or you just check it on my channel. Okay, I told us there how you can correctly position 3 cable ECG, then 5 cable ECG, and then the 10 cable ECG, which is the standard 12 lead ECG. I hope that makes sense. So this is a lot to take in, but I believe it's simple enough. So if you have any question, then you can let me know. Summarily, you can just say the lead 1 is the representation of the electrical activities or the potential difference between the right arm and the left arm. You can say the lead 2 is the representation of electrical activities or potential difference between the right arm and the left leg. Lead 2 between the right, lead 3, sorry, between the left arm and the left leg. Then AVR between the right arm and the heart. Then AVL will be a representation of electrical activities between the left arm and the heart. Okay, and AVF, representation of the electrical activities between the left leg and the heart. Okay, once you understand this, then I'm happy my goal is achieved, because my goal is for you to be able to make sense out of the ECG. Okay, so if you follow me this far, then I believe you are moving up the ladder gradually. Okay, and I will implore you to continue with me. Okay, I think I've still got maybe 2 or 3 more sections planned for the coming weeks. Okay, it's best if you've attended once and you make efforts to keep up with the sections. It's best for your understanding. Okay. If you can't, for any reason, attend it live, I'll definitely leave the recording on my channel for a couple of days, so you can always go back to it and study it. Okay. I have a book I've published on ECG, so everything I've been explaining, they are well explained in the book in a concise and simple interactive manner. Okay, it's just as if I'm talking to you. That's just how it is in the book. Okay, so the title is Synopsis of Electrocardiography for Nurses. Okay, you can get it on Amazon. You can scan the QR code. I'm going to drop the link in the chat box as well. You can come back, it will be in the description box. So just in case you want to improve your understanding of ECG, I will encourage you to have a personal copy of this. It's really, really going to help you, because there's no way we can cover everything in this section. But having the book is really going to help you. I need you to share this teaching with your colleagues, with your friends. Don't be stingy. It's definitely free. So don't be stingy. Make sure you share with your friends and your colleagues. And this video, if you feel you've learned anything from it, give it a like. That's going to improve the visibility, the engagement, so that more people can benefit from it. Give it a like. Drop your feedback as well. So that's going to encourage, it's going to get other people to see it more. Okay. So give it a like, give us a thumb up if you feel you've learned anything, and don't forget to subscribe to our channel so that we can form a larger community. When we have next section coming up, then you can be notified. I'm not sure which day it will be yet, but I will try my best to keep us informed at least 48 hours before the time. Okay, so Remember to subscribe and use the notification bell so you can get notified. So if you have any question, then you can put in the chat box as well. So that will be it for tonight. I hope it's worth every bit of your time. Thank you once again for joining us. It's a privilege to have you with us, and I'm looking forward to seeing more of you in our next sections. Thank you very much. God bless you all. Bye.